Okay, so I just wanted to welcome everyone tonight. We're just really, really pleased to have Palliative Care New South Wales with us, and it is a session that we have been wanting to do for quite some time. So I will introduce our speakers shortly, but I've just got our special and always present content warning. So I will start with an acknowledgement of country. I'm here on Camaragal land and I acknowledge them as the traditional owners, custodians of this land, and pay respects to elders past and present. Now, this is number 7 in our end of life webinar series, and we've got many more planned. One thing that we always say, and I think it's particularly relevant for this conversation, is that the discussion can bring up unexpected and difficult emotions. And the content tonight, it may well bring up memories of a loved one's death or their time in palliative care, or even just general feelings of grief or sadness. So if anyone's feeling that the content is getting a little bit much, just peel off. And you can always come back and watch it later if you want, or not, whatever. But it's not something that you need to persist with if you're really not feeling up to it. So if there's something that you really feel you need crisis support, there's always Lifeline or Beyond Blue. And we always recommend people who are feeling very deeply a loss or bereavement that they get in touch with Grief Line, and they've got great resources on their website and also a helpline. So let's move on and I can get to our guest speakers. Just an overview of the session. So we'll have our speakers for the first hour-ish and then the remaining 30 minutes for questions. So if people want to stay for questions, that's great. If not, just drop off, and then maybe if you want to, you can watch them later on the recording. So we will hope to get the recording out later this week or early next week. We really love people to use the chat function, which, depending on what device you're using Zoom on, it might be at the top or the bottom of the screen. And I've got David and Kendall. Can you give us a wave? They are my support crew, and they'll be monitoring the chat, also letting people in as they join, but they'll be monitoring the chat and we'll be collating some questions. We've had some in advance, which is fantastic. And Kendall and David will be pulling some out of the chat to ask later. And hopefully Kirsty, Kate and Peter might also do some responding in the chat when they're not talking. So as I said, we have been very keen to discuss palliative care in our end of life series, because the point of an end of life series is to discuss a range of things with end of life, and we've covered aged care, advanced care planning. We've obviously spent a lot of time focusing on VAD because that's what we've been really working on for 50 years. But the reality is that most people will not die using voluntary assisted dying. But most people would benefit greatly from palliative care, including those who opt to proceed down the voluntary assisted dying route. And what we know from the VAD data that we've had from New South Wales and around the country is that 80%, around 80% of people who apply for voluntary assisted dying are also receiving palliative care. So it's not an either or, it's both if people want that. And we've been very glad over the last few years to see more and more attention and funding for palliative care. There's very important work being done to expand its reach, particularly into aged care and also non-cancer diseases, and to educate the healthcare sector about palliative care. But there's not a lot of knowledge about palliative care in the community as a whole, and there's a whole lot of confusion about how and when to seek help and who to seek that help from. And none of this is helped by a general reluctance in the community and, unfortunately, the medical profession to even talk about death and dying or make end-of-life plans. An awful lot of people think that dying is a linear process. So you'll get your diagnosis, and then over time you'll get sicker. And then when you're about to die, you'll go to a hospice, and then a few days later you'll die and you will have been pumped full of morphine. Now, that is actually what I thought until I watched my best friends last year with breast cancer. And it was not like that at all. There were a series of crises, an accumulation of terrible new symptoms, deterioration in quality of life. And all through that time, she was being actively treated through a series of clinical trials. And it was a patient who was absolutely determined that she was not going to die. So a year before she died, when the symptoms got to the point where the oncologist was struggling to work out how to deal with them, she got advice on the symptom management from a palliative care specialist. And that actually was very significant in terms of not just pain relief, but also it then opened the door to a greater involvement from other palliative care services. And they were involved both on the medical side, but also helping manage things at home, arranging equipment. There were physios and occupational therapists, and they came to help not just the patient, but also the family and the carers work out how best to manage this situation at home. And there was also volunteer transport to and from medical appointments, which it reached the point where it was not possible for her to be transported in a car. And these volunteers would turn up with this quite alarming equipment, but they would manage to get her to the hospital for scans and things. She also had a couple of admissions to a hospice to stabilise symptoms, and then she went home again. So that's what palliative care can and should look like, with the aim of giving patients as much quality of life as possible before their death, but also providing support for carers and family, because anyone who's looked after a dying person at home knows that the burden on carers is really incredibly significant, and support is needed for them and not just for the person who's unfortunately doing the dying. So now I will stop talking, but I will just quickly introduce our three speakers. So we have Kirsty Blades, who is the CEO of Palliative Care, and she'll give us an overview of what palliative care actually is, and then some myths, and then some myth busting. She'll look at how you access palliative care, which can be a bit difficult, unfortunately, and there's a number of reasons for that that Kirsty might get into, or we might address during the questions. But also she'll touch on palliative care and VAD. And then we'll hand over to Kate Bowman, who is the Volunteer Services Support Program Manager. And I think we've said in our other sessions that dying, it really is a community situation. It needs not just the family and the doctors, it really needs the community of friends, neighbours and volunteers to help, because the process of keeping a dying person at home is very, very hands-on. And the volunteers that palliative care have in a whole range of areas, in the community, in hospices, in hospitals, it's a really, really important adjunct to the medical side of things. And palliative care have a lot of volunteers around the place, and we're actually hoping that some of our supporters might like to consider becoming palliative care volunteers. Then there is Dr. Peter McVeigh, who is in a role which I think is absolutely vital, and that's a palliative care guidance manager. And Peter will tell us what she actually does, but Peter's background is as a long-standing, very experienced nurse in palliative care, and without wanting to diminish the role that palliative care doctors play, they are not at the bedsides, at the coalface. So it's really useful to have a very experienced nurse to really talk about what actually happens and what is actually needed to support someone at the end of their lives. So I'll pipe down now and I'll hand over to Kirsty. So I'll stop sharing my screen and she can take it from here.
Thanks so much, Penny, for that introduction, and good evening to everyone. It's so fantastic to see so many people online for this session. Penny and I actually met probably about a year ago now. I think we were both presenting at some Dying to Know Day events. And what I really appreciated in my conversations with Penny was that real openness around the conversations of that role of VAD, the role of palliative care, and it certainly really opened up more conversations between both of our organisations, which has been really fantastic to see as well. I also do just want to acknowledge that I'm joining on the land of the Gadigal people of the Eora Nation. And for Palliative Care New South Wales, we have a strong commitment to walking with and learning from Aboriginal and Torres Strait Islander people on their care journey. It's really important when we think about palliative care and in terms of being equitable, accessible, that culturally safe palliative care is incredibly important. And there's a lot of work being done in palliative care and by the sector to ensure that palliative care is provided that is culturally safe, that we really are thinking about the different needs of everyone to ensure that they are receiving that culturally appropriate care. And that's really a fantastic and emerging area that we're seeing strongly in palliative care at the moment. So I'm going to kick off with, first of all, just talking about Palliative Care New South Wales, just quickly. So we have been around for just over 50 years. We're a peak body, a charity, and a not-for-profit. So we're a member-based organisation. So we have members who are clinicians, doctors, allied health professionals, people working in aged care. And then we actually represent all of those healthcare professionals, as well as people with a life-limiting illness, carers, and families as well. So we certainly have a strong connection into community. We advocate, a key thing that we advocate for through government and other channels is to ensure that all people can access quality palliative care support and services. Penny has already alluded to this a little bit, but the reality is that not everybody has equal access to palliative care. And that's certainly something that we remain focused on in improving that access as well. And that access, that limitation in access can be for a number of different reasons. It may be related to where you live and the services that are available in that particular area. But access is also greatly defined by awareness within the community of what services are available and how to access those. And that certainly we are funded by the New South Wales Ministry of Health to run community engagement sessions, as well as so we run a series of online, etc., where we're really aiming to increase that awareness of what palliative care is and how to access it through exactly sessions like this tonight as well. And awareness and education. So that's not only clinician education, so we're running conferences, education days for clinicians working in palliative care, but as I said, that awareness and education for the community as well. So the orange heart, you will see that it's on our logo. It's also, I've got my pin here, and this is the symbol for palliative care. And I really love this symbol. It was launched in May 2023, and the orange heart is a universal symbol for care and friendship. But one of the reasons that I love this symbol is it starts to talk to the beating heart that palliative care is supporting. That quality of life that Penny has spoken about is absolutely a core premise and focus for palliative care teams and clinicians. And I really think that this heart symbol helps us focus in on that, about that focus in on the living, the life part that we are wanting to support as palliative care clinicians and professionals as well. The 8 sparks coming out actually represent the 8 states and territories across Australia. So this is a symbol that's been introduced across all of Australia, so that we start to get that consistency and people seeing this and having that recognition and awareness of palliative care and that orange heart and what it means. So one of the things I would love to actually, see you would like to put this in the chat. We get lots, so I always ask this question in our sessions, is when you hear the word palliative care, what are some things that immediately come to mind? So very happy if you wanted to just start to put those into the chat to be able to see that type of information. And you'll probably see that there's quite a lot of different responses that can come up on that. So I'm just looking at here: dying, support, end of life, acceptance, lack of information, holistic care, life limiting, last stage. So yeah, we often, these are all very, common types of words and statements that we do hear when we're talking in the community. It can be that real depth and real breadth of different words that people can use, from fear. There can be fear when people hear these words. There can be a sense that palliative care means you've given up hope, that it does just mean dying, you are about to die. And then to the other extreme, we hear those words of compassion, empathy, quality care. So there are a lot of different words that people think about when they hear that word palliative care. And that's certainly one of the things that we like to talk about, because we want to just break down if there are those words that bring fear or those concerns if you were to hear some of those words as well. And so it's really great for us to think about what does that word actually mean, and think about where palliative care started. So it actually is considered to have been around for a very long time. In fact, they say it sort of dates back to medieval times. And a really important factor to be aware of is that palliative care has actually been declared by the World Health Organization as a human right. And I think that's something really important to hold on to, is that understanding that palliative care has been declared by the World Health Organization as a human right. Now, the word palliative has several meanings, and I always like a bit of a visual meaning to help us start to break down any fears around that. And one of those visual words is to cloak. And so when we think about palliative care and cloaking, so, to cover or to ease or to relieve symptoms. I also like to think about that cloak as that cloaking with that support system around you as well. And then if we actually go to the official definition of palliative care, what it states that palliative care is that it's a medicine or form of medical care relieving symptoms without dealing with the cause of the condition. So again, you can see there is no reference to death or dying in the official definition. The key focus in those words is about the relieving of symptoms without dealing with the cause of the condition. So we are not aiming to cure a condition. We are managing the relief of symptoms related to that condition. So I think that's a really important way to start to think about that definition of palliative care. And the palliative movement actually started in the UK in the 1960s. It started to gain momentum here in Australia in the 1980s. So really, in the scheme of health and specialist areas, this is still quite a new area that is continuing to develop and have advancements all the time. So again, I think it's just good to have some of that information and that background there as well. So if we now think about, I'm just going to go to the official definition and just reiterate some of these key points. So palliative care is for anyone of any age with a progressive life-limiting illness. So again, some really important points there. Anyone of any age. So there are babies, young children, adolescents, teenagers who will also be receiving palliative care and who are able to access palliative care. A progressive life-limiting illness, so something that is going to shorten your life. You might call this a serious illness, a terminal illness, but to be able to access, in particular, specialist palliative care, it is someone that has that progressive life-limiting illness. We consider it to be high quality healthcare that is managing not just pain and symptom management, so not just those physical symptoms that might be there, but it also extends to end of life care, grief and bereavement support, and social support as well. It's person-centered, so the absolute goal of palliative care is to put that patient at the center of those care decisions with a real focus on improving quality of life for not only the patient, but also considering what is required in terms of the family and the carer as well. And that, again, we come back to that quality of life, that focus on the living component. How are we ensuring someone can continue to live as well and as comfortable as they can right to the very end? Holistic. I think that, there's a lot of healthcare now that talks about holistic care, person-centered care. I will say that palliative care really, it was the pioneers in this space. We have always been doing this. This has always been a focus around that holistic support. So looking at not just what those physical needs are, such as pain management, nausea, breathlessness, but what are the needs from an emotional, a social, a cultural, and a spiritual perspective as well, and what support can come in at that point to support the person and the carer and the family. And it can provide access to resources. So Penny spoke about this a little bit. Again, now some of this, we will be completely honest, it will be based on where you are living and exactly the supports and services available around you. But certainly the palliative care teams are able to provide that advice and support on equipment that may be required to ensure that someone can stay at home if that is that person's choice and preference. And so that's where there are, some fantastic volunteer-based organizations that have that focus on having equipment available to families and carers. But certainly that is part of the team of what they are providing as part of palliative care as well. So that's sort of rolling up that definition of what palliative care is. Anyone of any age, progressive life-limiting illness, designed to address symptoms, not just physical, emotional, social, cultural, and spiritual as well, ensuring the person's needs are put at the center of that care as well. So I'm going to switch in to some common myths of palliative care. Now, I do find that more and more people are aware of that these myths are, they may know that they are indeed myths, but still it's really important to talk about some of these. So the first one is that palliative care hastens death. There can absolutely be a fear in the community that this may be the case. In fact, palliative care neither hastens death or prolongs life. Palliative care is designed to run alongside that natural progression of that illness or disease, with that focus again on the management of those symptoms to ensure that person is able to live as well and as comfortably as they can right to the very end. So that's an important thing to think about as far as that myth that can be sometimes out there in the community. Palliative care is only for people dying of cancer. So that is in fact a myth. definitely it is for anyone that has been diagnosed with a life-limiting illness. So that is not only cancer, that can include advanced dementia, neurological conditions such as MND, MS, Parkinson's, organ and failure disease such as advanced heart failure, kidney, liver, or lung disease. These are all diseases that are life-limiting and would absolutely be applicable for palliative care support. Palliative care, I will say though, it is still highly represented. There are still a lot of people who are accessing palliative care who do have cancer, and that is probably where palliative care really started. So you can see why there is absolutely a strong representation, as that is really where palliative care commenced, strongly working and caring for people with cancer. But it's important to know that it is not just for people with cancer. And in fact, today in our community, we see a lot of people who have a combination of that malignant and non-malignant. So both cancer conditions as well as non-cancer conditions within the community. So it's incredibly important that palliative care is providing support for anyone with a life-limiting illness. Palliative care can only be given in hospital. So it can absolutely be and is designed to be provided in a range of different settings, including your home. So it is absolutely now, there's been a lot of progress in this area with community-based palliative care, now available in most locations. Again, I'm going to put a caveat in there. That access, it will depend on where you are living and the services that are available. But now there is a significantly high number of community palliative care services that are able to come to your home to provide that palliative care support. Remembering that residential aged care is considered your home as well. But I will say, another caveat here is that there is still, you know, one of the things we're really strongly advocating for within residential aged care is improved training for all nurses within residential aged care to be able to provide quality palliative care. But absolutely can be provided in that home setting. You know, I've spoken to palliative care clinicians who are providing palliative care boats, caravans, you know, palliative care. As we said, this is for everyone, people who are experiencing homelessness. So absolutely can be provided in a range of settings, provided in the hospital setting, and this could be a couple of different scenarios. Most hospitals would have access to a specialist palliative care team who can come and visit into any different wards and beds and provide advice in that way. Or some may have a specialist palliative care unit with dedicated beds and dedicated access that way. This is also one thing we're advocating for more of, because there is a definite need to have more of these across our community as well. And the final one, hopefully we're already starting to talk about this a little bit, is that it is only for people close to dying. And this is one of the biggest ones we definitely want to break down and dispel this myth. Palliative care, we are absolutely advocating for early referral, and it can start as soon as a diagnosis has been given. But really, it is absolutely because coming back to that management of symptoms. So that referral to palliative care could occur at any time, and Penny gave this example as well, when symptoms become complex, difficult to manage, then that referral to palliative care should absolutely be sought. People could be receiving palliative care 2 or 3 years because they're receiving that support to manage those complex symptoms. Unfortunately, many people are not reaching out for palliative care until the very, very end. And so what the statistics tell us is that on average, people are accessing specialist palliative care 12 days before dying. We absolutely need to improve that. We really want to see those earlier referrals, so people seeking that earlier support through palliative care. And when that happens, it allows, again, coming back to that focus on how does the team help someone to maintain quality of life and to live as well as they can right through to the very end. So when that team can get involved and work through that, then they can really make that difference. If a team is only coming in, and that might be just a few days before dying, that's incredibly difficult to then work through and manage all of that as well, and can often be at a really traumatic time as well. So definitely want to focus on and really encourage people to consider early referrals, knowing that this is not just for the final days before dying. That is not what palliative care's intent actually is. So now we're going to switch through to how to access palliative care, and a couple of different things we're going to talk about here. So what we know in terms of palliative care, we would really hope that everyone could access some degree of palliative care through their GP or their treating doctor, particularly if their symptoms were not complex. And we would call this general palliative care. So with those less complex symptoms, that you're working with your GP or your specialist, they are helping you manage pain, any of those physical symptoms, but also providing referrals if required for anything else that requires addressing, that may be the emotional, the social, the cultural, all of those type of things as well. So we would really hope, and this is something again we're advocating for, is that for anyone with less complex symptoms, that your doctor can be providing that support as required. For complex and distressing symptoms, that is when a specialist palliative care team can provide support and when a medical referral is required. So that difference and what that trigger point is for a referral to specialist palliative care is when those symptoms are more complex, they are more distressing, the GP or the specialist is having trouble in terms of getting some of those symptoms under control. And absolutely at that point is when a referral to specialist palliative care should be sought. And in most cases, again, this can be slightly different depending on the location where you live, but that does require a medical referral from your GP or your specialist. The reason it requires a medical referral is because that GP and specialist still remains a core part of your care team. So they are still involved, engaged in those decisions, working with the specialist palliative care team at the same time as well. And that's why there is this emphasis on that medical referral being required. It is important to know as well, many people ask this question, but for specialist palliative care support, there is no cost to you for that specialist palliative care support in terms of the team, the nurses, the allied health professionals that are coming in to provide that support. It is covered by Medicare. There may be some out-of-pocket expenses if you did require certain equipment to ensure, if you wanted that person to stay at home or you wanted to stay at home, there may be some requirement for some equipment, as well as medication expenses related to what that person or what you may need as well. But that specialist palliative care team, they are covered by Medicare, and that support is provided by them. It is really important to know, though, that specialist palliative care teams are not providing 24/7 support. So they are coming in, they're looking at what those symptoms are, what they need to get that under control, how they're managing that, doing those referrals to allied health if they're required as well. But that it is not 24/7 nursing support, and that's an important thing to remember. And so to Penny's point, it takes a team there does need to be that additional team. If your goal is to stay at home right to the very end or for as long as possible, it's really important to be honest about what will you need to be able to stay at home? What support will you need? Because specialist palliative care is not 24/7 nursing support. The other thing I'll just highlight with palliative care and specialist palliative care, I like to call it the dip in, dip out. And this goes to the point of why early referrals can make a lot of sense in palliative care. So a referral can occur. That specialist palliative care team dips in. They're helping get a symptom under control. So you've got that quality of life. You're living as comfortable as you can. At that point, that team may dip back out again, and you may not need that specialist palliative care team for another month or 2 months. And then there's something that occurs, symptoms change, there's a deterioration, and that palliative care team needs to dip back in again. Dip back in, help with that symptoms and that support management, and get that back under control. And then they may dip back out again. So it's important to sort of see it from that perspective as well when it comes to those specialist palliative care teams. One big thing, never be afraid to ask your GP the question about palliative care if you're starting to think, I think we may need some palliative care support. It's really important. What we are finding incredibly more, and Peter will probably talk to this too, is you have to be an advocate for yourself, for your loved ones. You need to ask these questions because unfortunately your GP or even your specialist may not recommend it, may not suggest it. To those myths, they may also have some of those myths and misunderstandings in their mind. So it's really important that you feel confident to ask the question and to start pursuing well, we believe we do need some palliative care support. So how can we receive that? Who can we talk to? What's that process? So that's a really important thing to be aware of as well, and that we give as a piece of advice all the time. We really have to advocate, and we'd love not to, but it is the case and the situation that we do need to be doing this advocacy on behalf of ourselves and our loved ones as well. Penny spoke a little bit about this. I'm only going to really talk quickly to this, but carers are so important. If you are a carer, you have been a carer, you might be a carer in the future. I really want to encourage you to acknowledge that you are a carer, and to really think about that role and to be able to say, yes, I am a carer, and to know the support that is then available to you, because there is certainly a lot when you are taking on that carer role. So I just want to highlight, you may have already had a session on this, but there are carer allowance, carer payments, there are different financial supports you can get as a carer. So please do investigate those, because carers are vital in palliative care and end of life care. If you can get some financial support to support the work and the care you're providing to a family member, then please do reach out and seek that support. And there are some fantastic organisations such as Carer Gateway, Carer Help, and great technology now out there that can help you mobilize a team, mobilize your support network around you to provide care and support as well. And I would recommend looking at the Help app if you're wanting to mobilize that type of support. It sounds like you've had this discussion and a different session around advanced care planning and advanced care directives. This is such a crucial part of palliative care, and something we reiterate and we spend quite a lot of time with the community talking about is how important it is to start these discussions and to plan for this final stage of life. And I just want to quickly outline from our perspective why this is important. And clinicians, as we know, none of us know what the future might hold. So it's incredibly important that if something comes up, that we, feel better prepared and we've had those conversations. It gives you control. It gives you control when you've got the ability to start to think about the decisions you would want to make and the care you would want to receive. And we often say this can be the greatest gift you can give to your family, is to have had these discussions and to have done this planning as well. It actually has been proven to improve the care you receive because the focus, you've already had these conversations, you're all on the same page, and it can absolutely help with the provision of that high quality care. And it allows you then, if you've had these discussions, often these discussions happen at a crucial, traumatic time when you're trying to deal with so many other things. But if those discussions have already been had, everyone's on the same page, right then, your focus is just on that quality of life, of living as well as you can to the very end, because you've dealt with those conversations. You've done that planning. You're not trying to do it at a critical, traumatic point right then and there when you may be very close to that end of life stage as well. I mentioned this, but caregivers and patients puts everyone on the same page, and causes less stress for everybody. If there's one thing that palliative care clinicians repeatedly say to me when we're talking to them, what is the message for the community? It is, please have these conversations, start your advanced care planning, do your advanced care directive. Otherwise, when the teams come into your family and in to provide that palliative care, this is one of the first things they're going to have to do. And really, they would love that a lot of that was already done, those discussions are had, so they can get right into, okay, what are we going to do to ensure that we can maintain that quality of life to manage your symptoms now? So certainly, just reiterating the really important part of that planning. Okay, palliative care and VAD. So I think, legislation has been in place now for a couple of years, and I think the discussions of palliative care and VAD have progressed a long way in that time as well, as people have seen how does this work? How does this work? What are these interactions beside each other as well? So I just wanted to highlight from Palliative Care New South Wales perspective in relation to palliative care and VAD. Ultimately, for Palliative Care New South Wales, we're neither for nor against voluntary assisted dying. It's important to know that palliative care and VAD are two distinct areas of healthcare, different referral processes, different staff, and different teams. And the implementation of voluntary assisted dying has not changed what palliative care is or how palliative care is accessed or delivered. That is not within the scope of palliative care, but if a VAD pathway is chosen, then palliative care can continue to be provided or commenced. And that is certainly something that we see as incredibly important. If someone is pursuing VAD, then they're demonstrating they have significant suffering. And we hope that they're accessing palliative care as a way to assist manage those symptoms which are causing that suffering as well. So we absolutely really want to see that people that are pursuing VAD are also looking at that access to palliative care. We know we're very, that positive element of the legislation, which has meant that anyone considering or starting the VAD process must have palliative care discussed with them as an important care option. And that's been such a positive part of the legislation as well. And we know that still, it raises difficult and sometimes complex issues for different people. And we know that continues to be the case. This is a very personal choice that somebody is making. And so we really support the choices which are built in to the legislation, which does mean for those that are working in palliative care and any healthcare professional that they may choose to exercise that right to be recognised as a conscientious objector. We really our focus is on just that diversity of opinion, always having those respectful conversations and that understanding of the two, and that ability for both to be working side by side as well. And our big focus here when it comes to palliative care and VAD is that an individual's choice to explore VAD should never be a choice based on a lack of access to palliative care here in New South Wales, particularly in rural, remote, in regional areas. So we really just want to make sure that people are able to access quality palliative care, and that if they can't, that's not giving them the only choice when it comes to that end of life option. So they're ultimately that's an advocacy that we continue to be focused on, is how do we make sure people have access to quality palliative care here in New South Wales. That's going to wrap up my part and that first introduction. I am going to hand over to Kate Bowman, who is the Volunteer Services Support Program Manager. So here at Palliative Care New South Wales, we run a Volunteer Services Support Program, which has been running for 10 years. Kate is absolutely passionate about volunteers and has worked with this program for just over 9 years now. So is an area she's very well versed and has a lot of experience in. So Kate, I'm going to hand over to you.
Thank you, Kirsty. I'm happy to share my passion for volunteering with everyone. So palliative care volunteers provide psychosocial support to people managing life-limiting illnesses, to their family and their carers. They offer much needed comfort, companionship and respite, bringing ease and dignity, and their efforts remind us of the power of human connection and empathy. They offer not just help, but warmth, compassion, presence, and a listening ear. I thought we'd start off with some stats because I'm a research nerd. Part of what we do here at the VSSP is research into palliative care volunteering. So at last count, which was early last year, there were just over 1,000 active palliative care volunteers in New South Wales, 1,049 to be precise, working across 38 volunteer services. And these numbers actually reflect a bit of a downturn thanks to COVID shutdowns in the years before. Before that, we had about 1,600 volunteers, and numbers are on their way up again, thankfully. Volunteer services operate all over the state, from dense metropolitan areas to smaller country towns to remote communities, but they aren't everywhere. There are still some gaps in service provision. A public health approach sees volunteers as the bridge between health service providers and the community. And this approach works best when volunteers are connected to their local specialist palliative care service and are adequately supported by their management team. Mostly, volunteer services are operated by New South Wales Health and they're embedded into specialist palliative care operations, but about a quarter of them are governed by other types of not-for-profit organisations. Some of these are very grassroots community organisations. Some are entirely run by volunteers. So there's a few different governance models, but all of them rely on referrals from their local specialist palliative care teams and cooperate closely with local clinicians. Some of them, especially in rural areas, also accept referrals from other health providers such as, GPs and community nurses. Palliative care volunteers are active across a range of settings according to local need. Some are active in inpatient settings, such as a specialist palliative care unit or in hospital wards. Some are community-based, visiting people in their homes or in residential aged care. Some do a mix of both. Some volunteers don't even have client-facing roles. Instead, they might work behind the scenes doing admin support or fundraising or providing linen or doing other sort of home care equipment stuff. There's quite a range of roles. Volunteers also provide support to families receiving paediatric palliative care, either in their homes or at their cottage, the Children's Hospice, or at Manly Adolescent and Youth Hospice. So a little bit about the volunteer role. Volunteers provide psychosocial support carer respite, grief and bereavement support. They're the big three. So they might be taking a client out for a coffee or a walk, obviously depending on their health and capacity. They might sit and read a book or do some puzzles. They just basically spend time with their clients. It might seem simple, but this very basic human connection is important. A cup of tea and a chat goes a very long way. Not everybody has family. Many people are lonely, isolated, especially older people, and they really benefit from having a visitor. Volunteers typically are allocated a client and visit the same person for an hour or two every week. So they stay with them through their whole palliative care journey, which can often be months. The earlier the referral, the better the outcome. And in some pediatric settings, it can even be years that a volunteer stays with the family. So bonds form. They're also there to support the family and carers. Carer respite is a biggie. If any of you have ever had to care for someone who's unwell, you'll be well aware of how much effort this takes. Having a volunteer present allows the carer to just have a couple of hours off for themselves. They might be able to go have a shower or go get a haircut or, go to their own doctor's appointment or whatever they might need. Volunteers are also there to talk about the difficult emotions that go along with a life-limiting illness for their clients, but also for their family and carers. They might discuss, anticipatory grief as it arises, like listen to people's fears, be present for their emotion, just hear and validate them. Some services also involve volunteers in bereavement support groups. Writing biography or life stories is a new type of volunteer role that's kind of taken off in the last 5 years. There's now about 20 volunteer services that offer biography to their clients in New South Wales. Biography volunteers visit once a week, on average for about 6 weeks, and they create a legacy document about the client's life, compiling milestones and memories. And while it's nice for the family to have a booklet at the end of this process, this is actually more of a dignity therapy where the aim is to reconnect the client to their identity and enjoy time spent reflecting on their life. In rural areas, many volunteers help transport people to appointments, as sometimes they've got to travel for an hour or more to get to the big hospital for their chemo or other treatments they're having. Other volunteer roles might in grief and bereavement support, admin support, helping with events such as memorial services, manning stalls during National Palliative Care Week. Some maintain equipment such as special lift beds or manage wig libraries. It all depends on the needs and the capacity of the needs of the local area and the capacity of the local service to provide for them. As with other palliative care services, palliative care volunteers are available to people who are accessing VAD. Volunteers may not be aware of their client's VAD status as they're not required to disclose this information, but importantly, there's no difference in the support offered. Working in palliative care is one of the most rewarding volunteer choices anyone can make, but it is not for everyone. Not only does it make a huge difference to the person who's dying and their family, but it also makes a difference to the volunteer's own life. Volunteers learn to cherish each day, listen deeply, and value life as a precious gift. Death and dying, end of life, and palliative care can be difficult and sometimes confronting subjects for people to discuss. The volunteer role involves supporting people and their families as they grapple with these sensitive subjects. So sensitivity, empathy, life experience, warmth and communication skills are essential attributes. Volunteers need to be patient, flexible, non-judgmental, understanding and accepting of other people's beliefs and values so they can navigate people through difficult conversations. Volunteers come from all places and diverse backgrounds. They might be employed, they might be students or retirees. Most volunteer services ask for a commitment of 3 or 4 hours per week of your time. There's no formal qualifications required. Life experience and compassion are enormously beneficial. There's quite a process of an onboarding process. Volunteers are highly trained for their role and they're provided ongoing support. If you're interested in volunteering, I urge you to check out our Volunteer Hub website, which is full of information. We have a service finder where you can pop in your postcode and it will list the volunteer services near you and how to contact them. They all have their own intake times and processes, so please contact them directly if you're interested in volunteering. Our volunteer services support program, we host professional development, events and conferences to support volunteering. Coming up on the 18th and 19th of August, we're hosting our big biennial palliative care volunteering conference, which is exciting. We also do research, as I said earlier, and help to build capacity in the sector. We have a whole bunch of resources on our website. It's all there on the Volunteer Hub for you to explore. If you're interested, while you're there, I suggest you sign up for our monthly newsletter, which will keep you up to date with all the happenings about palliative care volunteering. And I'm very happy to answer any questions if you want to pop them in the chat. Thanks.
Thanks, Kate. And, I think that's really highlighted the important role that palliative care volunteers play in a palliative care team, and, how that's looking at the role of palliative care volunteers in that holistic, person-centered approach as well. So now I'm going to hand over to Dr. Peter McVeigh, our Palliative Care Guidance Manager. I'm not going to do too much of an intro because I think Penny did a great introduction to Peter as an experienced clinician with lots of great support. So Peter, I'm going to hand over to you to talk about your role and share some insights with everyone.
Thank you, Kirsty. So hi, everyone. So the role of the Palliative Care Guidance Manager commenced at the end of 2022, and a large majority of my role is about responding to questions from the public, health professionals or organisations, offer advice, guidance about further supports, and direct them to helpful resources. Next. So who calls us? So can you see on this pie graph that the green, 60% are from the public. And the next group of people is health professionals, 26%. And most people find us by doing Google Internet searches. So what is the most common questions I get asked? And the number one question is, what is palliative care? So people want to know what it is. And like most of the general public, and Kirsty mentioned this earlier, when people first hear the words palliative care, they immediately think they're going to die and they're going to die very soon. And so people are very frightened about the word palliative care. And palliative care is more than just end of life care. It's more than the last few weeks. It can be part of someone's life for several years. And so often it's an explanation about me explaining what palliative care is. And what I normally try and do is focus on, improving quality of life. And how do we do that? So it's about identifying what are the issues for that person and their family. So, it could be physical symptoms, it could be spiritual, it could be psychosocial, it could be anything. But we need to find out what the issue is, so do an assessment, and then develop a plan of action so we can improve that issue. Now, the other thing is that people hear a lot of information, but they often don't retain it. So it's really important to have written information that people can hand out to other family members. And so we have lots of valuable resources on our website. But the number one resource that I continually go to is the Palliative Caring booklet. And you can see here on the slide, you can click on various chapters, you can download the whole book, or if you want a hard copy, you can ask us to send you a copy. So it really is helpful to have this written information. And so how do you find a palliative care service? So palliative care services are broken down into geographical boundaries. And so it can be difficult to know, where services are. And so we've developed this palliative care service directory to help pinpoint those areas. And so far we have 182 services, specialist services listed. And these are specialist services, so they have specialist training and certification. And while there are many other services that list they have palliative care knowledge, they may not have the credentialing standards. They may differ. So we don't list every service that vouchers that they can do palliative care. So you can find this by going onto our website and clicking on New South Wales directory, and then you can type in your suburb or postcode, and then you choose the radius you want to search in. So if you're looking at regional or rural areas, they're quite sparse, those areas. So you might want to click in a radius of, say, 100 k's to actually find a service. Whereas a metropolitan service, you might want to click on 25 k's as the radius. So as mentioned before, palliative care is a specialty. So as such, the majority of services require a medical referral, and that referral can come from the GP or it can come from any other medical practitioner involved in the case. So what does the local palliative care service look like? So there are huge variations and it depends on where you live. Most hospitals have access to palliative care. Many have palliative care specialty services on site. Others call them in. You have palliative care dedicated wards in most of the major hospitals now, and you have your dedicated inpatient units, which we used to call hospices. So there are lots of community-based palliative care services as well. And residential aged care facilities can access consultation support from specialist services. So the team might include specialist nurses, nurse practitioners, clinical nurse consultants, registered nurses, access to medical specialists, or allied health team members. So that can range dramatically. You can have a full range of physios, OTs, speech pathologists, dietitians, or some may just have a few of those. So it really is dependent on the geographical location. I also get a lot of questions related to people in hospital or about to be discharged from hospital. And family members, ring and say that their family, the person they know is in the public or private hospital, they're about to be discharged, but no one's discussed any discharge plan. Or it might be that the family member is in a hospital with ongoing symptoms and they don't feel that they're being managed appropriately. So I think both these questions are really about the family advocating for the person and requesting a palliative care consultation. So everyone has the right to ask for a palliative care consultation. And, busy hospitals sometimes, not registering, not recognising this. And so, I do advocate people to ask for it. I did say that not all hospitals have palliative care teams on site, but they do have access. So the other thing is when people are being discharged from a hospital, the palliative care team can make appropriate referrals to community services and additional supports. And quite often the allied health teams involved can do home visits prior to going home to set up the equipment. Now, I also get questions about increased support at home, and there is different support programs available. We've got a lot of the aged care support programs, which are federally funded, and we've got the state programs, which are funded by New South Wales Health. So there are a huge variety, and people get very confused about them. But if we look at most of the packages, really what they're doing is providing practical help. So help with showering, cooking, cleaning, that sort of thing. So for anyone over the age of 65, there are short-term aged care packages, particularly if you're being discharged from hospital. There are packages that will last 12 weeks to help support you going home. There are also ones to help restore function if there's been a decrease in that for people at home. Then you have your long-term packages. So you're probably all aware of these, your level 1 to 4, 4 being your highest package, 1 being the lowest one. And this is where the government contributes, but you also might have to pay a fee, and often they're income tested. So there could be some additional costs. And so these aged care packages are accessed through My Aged Care. So from the 1st of November, you've probably heard that there's changes happening, and some of these packages will change. But I think the one thing that is coming is the new end-of-life pathway package. So this is going to be provided to people who have a prognosis of 3 months or less and wish to remain at home. So, you know, that they will be eligible for the package once they're assessed. So if we look at the state-funded packages, so this is for anyone, you don't have to be over 65. You can get short-term packages of care. So again, they're about 6 weeks long, and they're for people being discharged from home. There are also the New South Wales Health end-of-life packages. So these are for a 6-week period, but can be repeated for people in the last weeks of their life. But we need to remember that all of these packages are really about practical supports. So help with showering, cooking, that sort of thing. They don't actually, they're not specialist palliative care. So with all of these packages, specialist palliative care need to be involved as well. So there's 2 groups going in. You've got the package people and you've got the specialist palliative care people going into for ongoing monitoring and comprehensive symptom management. And then you've got palliative care in residential aged care homes. So while many aged care homes state that they have trained their staff up and are knowledgeable about palliative care, some are very good and some are still finding it a challenge because of the high turnover of staff. So specialist palliative care services can go into these aged care homes and provide consultation and advice to help the residential aged care facilities. And to find the closest specialty service for that residential aged care facility, it's about going onto the service directory, and you'll find that information there. Palliative Care New South Wales has lots of educational resources and short online courses. And the one that I just wanted to point out, which is on your screen, is PalliLearn. So this is an easy to understand short course, really designed to improve knowledge and build skills around palliative care and end-of-life care. And you can see that there's a series of 8 sessions. They last 60 minutes. They're free. They're all online on Zoom. And you don't need any prior knowledge or experience within health or palliative care to join these. So the next series starts on the 2nd of September, and you can book these online. You don't have to go to all of them. You can pick and choose which ones you're interested in. But you can book online and they're open. I think they're open now, possibly, I think. Yeah, they are.
Yep. Yeah. And then just to conclude, before we open up for some more questions, just as an extension of that as well, we do run 90-minute in-person sessions in the community, actually very similar to a lot of what we've discussed here with you tonight, but we do include a much longer session around advanced care planning and the importance of that, and tips and tricks to get you started on that advanced care planning and completion of your advanced care directive. So that program is called Community Conversations. If you're part of a community group and you would like us to come into your community to deliver this in-person session, you can go onto our website and submit an EOI form, and then we can work with you to find out a time to make that work as well. So that sort of summarizes, we're going to wrap up there. Obviously quite a lot to cover in that time, but hopefully there's been a range of information that's been valuable around what palliative care is, how to access it, the volunteering element of palliative care, and then starting to talk about some of the specifics around palliative care from that clinical perspective as well. Our details are here. We're very happy for anyone to reach out for us at any time, and we're going to answer some questions now, but we are just going to go to one that came in prior to the session, and I'm going to direct this to Peter. The question that came in prior was, what is palliative sedation and how and when is it used? And this absolutely is, sometimes the use of sedation or opioids in palliative care can cause some concerns for people. So Peter, would you like to answer that one as far as what palliative sedation and how and when is it used?
Yep, sure. So palliative sedation is the administration of a medication to sedate a person and to relieve extreme uncontrolled symptoms. So it's really considered the last resort where all other methods for treating that symptom have failed. So it's about giving a medication that's carefully considered and titrated to reduce the conscious level of that person. So it's not purposely given to knock them out totally. It's to help make them a bit more sleepy and drowsy, so their symptom is a bit more bearable. But there's some structure around palliative sedation, and normally the physicians will discuss that with the person if they're capable of, have capacity, and inform them and obtain consent from them. If they don't have capacity, then they will speak to the family and get their approval to actually start this. But it's normally done in extreme cases. And it's really important that we understand that sometimes people think this is a form of euthanasia, but the difference is the intent. So what the intent is around palliative sedation is to relieve that extreme burden of intolerable suffering. And normally, as I said before, it's the last resort. Everything else, every other treatment management has been tried and not worked effectively. So I think that's the difference there.
Fantastic. Thank you, Peter. I've just been having a quick scan through some of the comments and the questions as well. I guess, and then I'll hand back over to you, Penny, but someone has made a really valid comment about palliative is not a word in Aboriginal communities. The term compassionate care is more gentle. And I think that that's a really good point. And what I was saying about culturally appropriate care is we find that there will be language differences that are used in different situations and for different groups. And we particularly find that for culturally and linguistically diverse groups as well, where we may use the word supportive care instead of palliative care, because in some languages, there's actually not a word for palliative. So when a translation happens, that can make that very challenging. And then another comment about requested a referral from a relative, or the oncologist, the doctors refused to do so. Peter and I were having this discussion before. So what is our recommendation there? And really it is, continuing to do that advocacy, but then ultimately finding another GP, finding someone that's actually going to look at that referral and to do that for you. And we've had several people who have had to do that and it is not a great situation. It is certainly not one we want to see, and there is a lot of work being done in this space as far as education for GPs, so that there is this greater awareness of when a palliative referral should be done as well. Penny, I'll hand over to you if you've summarised a few other questions.
Okay. So thank you for that. That was all very comprehensive, and I think that is the thrust of some other questions along the same line, is that the geriatrician said that it was the GP that had to refer, but the GP said they didn't know enough about to know whether it was palliative. And there is definitely a legacy of hospice, last days within the medical profession, but it is not helped by the fact that they are very uncomfortable telling people that they are at the end of their lives or that palliative care is available. And I think there's a range of potential reasons for that: a sense of failure in themselves as a doctor, or I've heard it expressed along the lines that they don't want the patient to lose hope. So you don't tell them that they're at the end, because then they'll give up the will to live. But it is pretty clear that giving false hope is worse than no hope, and people really need that time to prepare, because as you pointed out, if you leave things till the last minute, it may be too difficult to really address a lot of the symptoms. And you're right, it is unfair to ask a dying person or their exhausted carer to go in to fight with a GP or an oncologist to get a referral to palliative care, and it should not be required. But unfortunately, that's the healthcare system that we sometimes live in. And what I'm hoping, and people do ring us about this, and I'm sure they ring you about it, and we are happy to talk to people about, giving them a bit of oomph, if you like, to the confidence to be assertive enough to advocate for your loved one or for yourself. We wish that wasn't necessary, but sometimes it is.
Yeah. We have as well. I think, positively, we are seeing a shift in people in healthcare generally, upskilling in general palliative care, being more aware of it, and that need. And so, as an example, there were recently scholarships offered for general healthcare professionals to undertake palliative care training, and the response was overwhelming to those scholarships, which is positive that there are more people wanting to talk about it. The other thing on our website that, could be useful if there is really a struggle, we do have a GP flowchart on when to refer to palliative care. And, it could be that it is that taking that in, making that direction. This is, I believe we tick all of these boxes and should be looking for that palliative care as well. But Penny, you highlight a lot of what we hear is that there can be a sense that medical professionals are so focused on the cure that it's very difficult then when it is that sense of failure, etc. And for even medical degrees, this may not even be discussed in a medical degree, is end-of-life care, death and dying. So quite a lot of work we still need to do there.
Yeah, and I think that, if it's any consolation to people, we know that work is happening, but it's like it can take decades to change culture in the medical profession. And we also, unfortunately, have a very fragmented system, with some dealt with by state, some by federal, and then certain things are covered through the aged care system, but that's fine if you're over 65. And I know that some people with these long-term, slow deteriorating conditions can get some NDIS funding, but that's not always the case. I'm also thinking that we need to expedite our webinar on carers, because so much depends on the carers' knowledge and capacity, and also their mental and physical health.
Yeah, absolutely.
So a couple of other things have come through. A question about, there's a lot of interest in volunteering, so hopefully we can get your slides and send them around along with a number of links, and we'll circulate that when we send out the recording.
Yes.
A question about whether or not doulas can be palliative care volunteers, and we spend a lot of time talking to doulas because they actually can be an invaluable source of help for the carers, but they can also help navigate some of that interface with the clinical side. But as I understand it, there is no impediment to a doula being a palliative care volunteer as long as they're acting in their personal capacity. Is that how
Kate,
it
do you want to
is?
take this one?
Yeah. So yes, the services have pretty strict rules and professional boundaries that they expect their volunteers to adhere to. So even if like someone is a doula, that wouldn't necessarily exclude them from being a volunteer as long as they were prepared to operate within the boundaries that were expected of them. Having said that, it's up to each service to who they choose to accept. So there's no blanket statement I can give you to say that they all will or they all won't. Like each service accepts volunteers on a case-by-case basis.
Okay. Now, Kendall and David, have you seen any questions coming through that haven't been addressed already? Okay. Now, one thing that has struck me during the course of the day, and this is after an email from someone who's recently lost a mother who was in palliative care, and they've found themselves obviously grieving, but they found themselves to be feeling terrible, guilty, and traumatized about the process of their mother's death. And I think from reading it that a lot of what was experienced was what is considered to be very normal at the end of someone's life, with the strange noises and jerky movements and, you know, some delirium or confusion. And I think, again, this is part of the problem we have with people not talking about death, is that there's no general discussion about what actually can happen when someone's dying and what is something that is not a sign that the person is suffering. And just looking at your website, I can see that you've got a big volume of things that talks about things like the secretions that can gather at the back of someone's throat and cause the death rattle, and a lot of the time the person is not conscious of any of that going on, but it can be very distressing for the family if they don't know to expect that. So I just wondered maybe if Peter could talk a little bit about those types of things that can give people comfort when they're sitting with someone who's dying and strange things happen, and how we might go about finding out how to prepare yourself for that. Is there like a handbook of things to look out for, that when you should be worried or when you should just be able to sort of sit through it?
Yeah, happy to talk about that. So when a person is getting close to death, what's happening is the major body functions are slowing down. So the heart's slowing down, so the heart can't pump the blood around the body. And so what you're seeing is the hands and the feet are feeling cold, and they might be that mottled colour. So, you know, that's demonstrating the heart slowing down. There could be breathing patterns. Often, you know, someone might take long, slow breaths, and then there's big gaps in between. That's the lungs not beginning to function anymore. So all of this is getting very close to the last few hours, really, particularly the breathing changes. And you talked about the secretions at the back of the throat that collect when someone's, you know, semi-conscious, unconscious. And that's because their gag reflex, they haven't got one anymore. And so it just sits at the back of the throat. And some people are, you know, it makes a dreadful sound and it sounds really scary, but it's not painful. Some people try, and some health professionals try and suck it out with a suction machine. Unfortunately, that just stimulates more saliva. So the specialist palliative care team would suggest an anticholinergic drug to dry up those secretions, but it needs to be started really early. The first time you hear it, that's when those medications need to start. If it keeps going for a bit and you try and use those medications, you know, 12 hours later, they're probably not going to work very well. But, you know, it's also positioning the person. You know, if you position them in a different angle, that might help that. And so I think it's really about the family being aware of what's going to happen and these different changes, because I've been in situations where families don't know what's going on. They start to panic. They think something drastic's happening and they keep ringing the buzzer and they're panicking. But if they understand, you know, these are the things that you might see, and this is part of the dying process, then everyone is a bit more at ease. And there are, you know, medications to help reduce some of these things, particularly someone who's got extreme confusion. Maybe they do need some light sedation to help them be more restful. I don't mean sedate them so they're unconscious, but just a little bit to reduce, you know, that agitation that they've got. And so there's a combination of medications that specialist palliative care service use at end of life to, you know, for someone who's got that gurgling sound, agitation, restlessness, just a touch of that to help ease the person into a restful period.
Thanks, Peter. I know we've only got where I was just doing a quick scan down a couple of things. Someone mentioned Catherine Mannix has some very excellent resources, and there is an excellent video to this point that Catherine Mannix it does the voiceover for. So I'd really recommend having a look at that. And maybe when we send these slides out, we can include that link. And then a question about support available for people living with dementia, specific palliative care training. So Dementia Australia, please go to the Dementia Australia website. They have fantastic resources, and there is a program run by Dementia Australia called the Nightingale Program, which is specially trained palliative care physicians for people with dementia. It does not operate in all areas currently, but is certainly one that it is in a couple of areas in New South Wales and might be one to have a look at. So that's a Nightingale program with Dementia Australia.
Okay, well, I think we are right on time. And so thank you, Kirsty and Kate and Peter. And I really hope that our audience is feeling a little bit more confident and maybe assertive if they have to be. But I've just been thinking about this in the context of the effort that we put into preparing for the birth of a child, where we read everything known to man and we buy everything known to man, often things that are not needed. But no one has those conversations about death. You know, endless hours are spent talking about birth experiences and planning and how you're going to sort out the nursery and all of that sort of thing. But we never talk about how we're going to organise the care of a person who we know is dying. So I think the message is, and I say this every single time, we have to talk about it and we have to be open and we have to plan early, because things just get worse if you leave it till the last minute on a number of levels. So that is Penny Hackett's lecture for tonight, but I hope it's been useful, and I'm really grateful to Palliative Care New South Wales for coming along, and we may well do more of these sessions if people want them. You know, whatever is going to be valuable to people, we want to be as practical as possible. So I hope that we have been. So in the next week, we'll ping out the link to the recording and all the various slides, and also the important links to Palliative Care New South Wales. There's fantastic information on the website. I just spent quite a long time trawling through, and there's all sorts of interesting things. So I would very much encourage you to go there.
Thank you,
So
Penny,
thank
and
you,
thanks so
everyone.
much for the opportunity to be invited to do this session as well. We really appreciate it. And thanks to everyone for logging in.